Good.
All right, so 55-year-old male with some blurry vision, possibly needs glasses. He has a history of diabetes. He takes metformin and pravastatin, fluoxetine, vitamin D. Vision's 2032 OU with J10 near. IOP is 18 and 13. This is the first image here.
So, fundus photo of the right eye, medial looks clear, the nerve looks good. The attention is drawn to just the numerous dot-blot hemorrhages scattered throughout the macula and then also nasal to the nerve as well. The vessels look okay. The macula looks flat, also some hemorrhages overlying it as well.
Yeah, that's pretty good.
Is there some like I guess some whitening, just like nasal to the nerve as well, some spots.
And this may be like a little conval spot, some exudate, stuff like that. Maybe this is camera flash, I'm not sure.
Same thing, fundus photo of the left eye now, and medial looks clear, nerve looks good. Same thing, a lot of hemorrhages just throughout the retina. Again, some continental spots, and then maybe could be artifact or some exudates, like superior to the macula.
Yeah, I would say that looks like exudate. Yeah.
And then just for grading purposes, there's the 4-2-1, which I'm not great on. So it's hemorrhages you're looking for, and then the other thing is you're looking to see if there's IRMA, right? What's the 2?
Venous beading.
Venous beading is the 1, isn't it?
I thought it was
No,
2.
it's
IRMA's the 1, okay.
IRMA's the 1.
Okay, so is there any venous beading or IRMA?
I don't see any venous beading.
You wonder about that, maybe. It's hard, IRMA's a tough one. So I don't know. But anyway, so I would think, because you're trying to figure out the prognosis, so hemorrhages, venous beading, IRMA, and then neovascularization are kind of all things you want, sort of pertinent negatives to document on your exam. I don't see any neovascularization. You?
I didn't see any.
Just because of our glaucoma. Yeah.
Okay, all right, go ahead. Good. All right, thanks, Colin.
Okay, an OCT of the right eye. The layers look good, maybe a little bit of intraretinal fluid potentially. I guess that would be closer to the nerve.
Good.
Yeah.
And I guess some exudates next to the fluid as well. But besides that, nothing else.
They're called intraretinal hyperreflective dots. All right, because you can't tell they're exudates
Right.
without looking at it. So, because you see those in macular degeneration too.
So OCT of the left eye and similar, it looks like there's like a possible small pocket of fluid, just nasal to the fovea, and then a little bit of hyperreflective dots surrounding it as well.
Nice.
Yeah, agreed. Just
So this FA of the right eye. I guess is there some leakage? Maybe here.
Can't tell that till later. So in the initial image, all you're doing is looking at hyper and hypofluorescence. So you're saying, if you see something changing, you can say if there's leakage.
Okay. So there's some spots of hypofluorescence inferiorly.
Good.
And then I guess some scattered punctate points of hyperfluorescence throughout the retina as well.
Perfect.
Yeah, and these spots, like, you could potentially call them like ischemic areas.
Might be the hemorrhage blocking too. So your choice is, when it's dark, it's either blocking or hemorrhage. I think those are probably hemorrhages. And then, do you see any neovascularization? Because that usually jumps out at you.
I don't think so.
And any non-perfusion?
Blocked areas.
I would say no on the non-perfusion. No venous beading and no IRMAs.
Yeah, there's like very late, you could maybe say this is like either leakage from the staining, or I wouldn't necessarily.
It's all leakage, where it smudges out all over the place. That's all. You got all the microaneurysms slowly leaking. So if you look at the little white, all those bright areas are kind of around microaneurysms. It was interesting. I'm old enough. I think I'm the only one in the room. When we first got OCTs and we were looking at the diabetics, looking at this, were you when we first got OCTs?
I was,
You were pre-OCT?
yeah.
Oh, goodness. She always looks like you're 30 years old. So anyway, so I would look at this and I would look at the pictures and I would think this would be a clinically significant macular edema. Because it looks like the fluoresceint's leaking, the pictures, you got the microaneurysms, it's within 500 microns of the center of the fovea, and I probably would have lasered this patient pre-OCT. And then you get the OCT, you're like, oh, I
Well,
guess it's not
it
really.
is nicer coding when you have
Right.
a diabetic patient, you want to do anti-VEGF, and the insurance company requires you to have macular edema, and there's nothing on the OCT. You just-
Well, yeah, I would always say, yeah, I always say, all my diabetics charts have macular edema, whether it's mild or trait. All right, so go ahead, Jay. Keep going.
And then this is FA of Valenti, and just similar findings, some funny spots of hyperfluorescence throughout.
No.
And then I guess there's less like spots of hypofluorescence, but I guess similar findings to the right eye.
Yeah, I agree. So yeah, I mean, 55-year-old diabetic, a lot of dot-blots, microaneurysms, exudates, cotton wool spots, small areas of blocking, possible. I said possible areas of non-perfusion, but yeah, some of them probably are with the hemorrhage. So what do you think it is?
I'm most likely diabetic retinopathy, probably, I guess I'd grade it severe, non-proliferative. Other differentials, hypertensive retinopathy, radiation.
You use fascioscapular muscular dystrophy with retinal vascular changes. A little pressing. I had a patient with that. I had a patient come in once with retinal changes and it was associated with that. I always remember that. Good.
Yeah,
Oh,
that's
HIV does look like that.
basically what I got, anything like microvascular. So yeah, it is severe NPDR. In general, it's leading cause of non-infectious blindness in the US for adults aged 18 to 64. About 30% have diabetes as of 2021. 26% of adults in general have diabetic retinopathy, so pretty high prevalence in that population. It's associated with a lot of factors: socioeconomic status, African American heritage, duration of diabetes, uncontrolled blood sugar, hypertension, dyslipidemia, pregnancy, and smoking. There was a Wisconsin epidemiologic study after 20 years of diabetes, about almost 100% of type 1 diabetics and about 60% of type 2 had diabetic retinopathy, so it's just a matter of time. In terms of the pathophys, it's a microvascular disorder, involves pericyte loss leading to basement membrane thickening, narrowing of lumen diameter, and loss of endothelial barrier function. Hyperglycemia leads to damage of retinal capillaries due to formation of the advanced glycation end products. They cause cross-linking and can damage and upregulate pro-inflammatory cytokines. This compromises the vascular walls, causing microaneurysms, and these aneurysms can rupture deep and cause dot-blot hemorrhages. Capillary occlusion occurs due to activated leukocytes adhering and damaging vessels, causing infarctions of the NFL, which is cotton wool spot. And then inflammatory cytokines can result in endothelial damage, increased vascular permeability, and possible DME. This just kind of shows it here. And there's the sediment from the leakage left behind leads to the hard exudates we see. Continued ischemia can lead to upregulation of proangiogenic factors such as VEGF, and that can stimulate neovascularization. So in general, it goes capillary leakage, occlusion, and then sequela of retinal ischemia, including neovascularization, vit-heme, tractional RD, and neovascular glaucoma. Symptoms-wise, just decreased vision, fluctuating vision, floaters, visual field defects, metamorphopsia. In terms of the signs, there's an NPDR classification. It's based on the ETDRS trial. Standard images, which I'll show on the next slide. For mild, it's basically a few microaneurysms. For moderate, it's an increased number of microaneurysms, dot-blot, cotton wool spots, hard exudates may also be present. And severe, you have either of the 4-2-1 rule, so 4 quadrants of diffuse retinal hemorrhages and microaneurysms, or 2+ quadrants of venous beading, or 1+ quadrant of IRMA. DME can occur at any stage and should be an indication to treat. So this is a picture of DME. Originally classified as clinically significant or non-clinically significant macular edema, so symptomatic or asymptomatic. So the original classification, which is probably more important for the exams, in case they ask you about that. Retinal thickening within 500 microns of the foveal center, hard exudates within 500 microns of the center or adjacent to retinal thickening, or retinal thickening of at least 1 disc diameter within 1500 microns of the foveal center. Now it's more center involving versus non-center involving DME, which is thickening in the macula involving the central subfield or the central 1 millimeter. These are the standard photos. So, top left, you have a couple MAs here. Image number 2, you have some dot blots. Image number 3, you have some hard exudates due to some edema. Image number 4, you have some cotton wool spots, more severe in this case. And number 5, you have some IRMA, I believe, right over here, as well as some venous beading here. So these are just the standard images that the classification system is based on. I think there's a lot more. I'm just talking about NPDR today, but there's a whole bunch of other images for the PDR as well. In terms of complications, you can get ERM, you can get vitreomacular adhesion, vitreomacular traction, tractional RD, and you can get some disorganization of the some of these intraretinal structures, which is a poor prognosis. And as well, if you have disruption of the ellipsoid zone ELM or an ERM in general, any of these features, you have a poor visual prognosis. I think, correct me if I'm wrong, I'm not sure about this one, but the drill, if you were to wait too long to treat, that's when it would result. So you probably want to treat this more promptly.
Yeah, it's a late finding, and it's probably somewhat ischemic related or probably past problems. I mean, some of these eyes you see them later when they're better, and so yeah, so the drill is just a late finding. It's best just to treat based on the guidelines. I like your center involved macular edema. It's aggravating that they make you guys learn CSME because it's totally unimportant.
Yeah.
It's the center involved is where we make our decisions now.
For a long time, I thought CS meant center sparing.
Oh,
Oh.
For like a
it's
year.
logical, yeah.
Yeah.
CI and CS,
Yeah.
yeah, because clinically significant is just unimportant. But I do laser rarely, but the center involved is where you make the decision. This is great. Keep going. You're doing a great job.
Yeah, and then finally treatment and prevention. So with obviously with prevention, you're gonna try to have them do tight blood glucose control. Every 1% of reduction in the A1C results in around a relative risk reduction of 21%. I believe that was the DRS trial that found that. I kind of forgot. The UK prospective diabetes study and diabetes control and complications trial. Actually, yeah, those were the two. Sorry. Yeah. Diabetic control and complications trial is the one that found every 1% reduction in A1C results in that. And then UK prospective diabetes study was, I believe, in type 2 diabetics versus this one, type 1. For the treatment wise, the mainstay is intravitreal anti-angiogenic injections. So either VEGF or in the case of faricimab, VEGF and angiopoietin-2. Periocular or posterior steroids may also work in certain cases that are resistant. I just sprinkled in some DRCR protocols here. There's a whole bunch more than this, but that would take too long to go through all of them. I just had some highlights. I kind of just picked them out at random, the ones that look good. So in B, you have intravitreal triamcinolone versus laser for DME. Laser was found to be better in that case. For D, vitrectomy for DME versus DME, excuse me. Good for patients with significant tractional components. So you don't want to do a vitrectomy in that case. Ranibizumab versus triamcinolone in I with laser for DME. Ranibizumab with prompt or deferred laser was found to be better than triamcinolone. And then for P, DME after cataract surgery only occurred in a small percentage. Good to know. And then Q was history of non-center involving DME, and DME increases risk for center involving DME after cataract surgery. For T, this one was a pretty good one. Compared bevacizumab, ranibizumab, and aflibercept. So in general, a lot of the trials kind of showed that they were equivalent for the most part. Either bevacizumab to aflibercept or ranibizumab to bevacizumab, and then by transitive property, all three. But this one showed that aflibercept had better results in terms of the vision if you started it with a patient who had DME with vision worse than 20/50. However, they did.
And I think that's the only treatment, naive trial of anything, which found one of the anti-VEGFs to be superior.
Yeah,
So that's
most
why
of them
they-
found it was equal. And then they did an extension trial, the TX 5-year follow-up study. And I don't remember where I couldn't really find it when I was looking all this up again. But I think they put into question whether aflibercept was really better. I think the average vision it's slightly worsened from years 2 to 5 with no corresponding change. So it may not be significant, but it's probably best to just go with it. Yeah, I don't know. Do you hear anything about that one?
I didn't hear the extension one, but I heard something about it.
by
I think you're
year
right.
2, they were all kind of equal.
Right, yeah, I think you're right. It didn't make a big difference
Yeah.
long term.
I think for the first couple of years, maybe, and then after that, it didn't. And then for the U, is for resistant cases, ranibizumab and steroid group improved more than the ranibizumab alone. And for V, if this one's also quite important, if the patient has center involved DME and vision better than 20/25 or 20/25 and better, they found that there's really no difference whether you treat it or not. So don't subject your patient necessarily to it if it 20/25 and better. And then for W, aflibercept given to moderate to severe NPDR did not confer a benefit at 2 years compared to treatment initiation at PDR development. Now, Dr. Cohen, for that protocol V, do you generally defer for 20/25, or you just go ahead and
Yes,
treat?
that's actually one of the ones that I remember,
Yeah,
in
would
my
do
head,
that.
I think of the V as very good
Very
vision.
good vision.
And that's the only one I remember. And so I did, if they're 20/25 or better. Having said that, there are some people, I had a doctor who was really difficult and wouldn't let me treat him, and he finally was getting worse. And somehow he had a 20/20 or 20/25 eye that I treated, and he felt he was subjectively much better. So it's interesting. So there is 20/20 and 20, good 20/20 and bad 20/20. So if the patient's bothered, I think it's always a reasonable idea to treat. But I often defer treatment, even with a pretty thick macula. I'm like, wow, I can't believe you see well.
Interesting.
So the OCT scan is not as important as the vision.
Yeah, you do watch them though, because
Yeah, well,
they'll start to slip, and then you want to treat them, but
Right.
Do you do a lot of contrast vision testing in those type of patients to see if they're 20/25 unhappy?
What do you mean by what kind of vision testing?
Like contrast, like make
Oh,
it
no, we don't have
contrast.
No, that would be interesting. Contrast readings, all the other parameters would be interesting, but I've not done that. Do you have contrast in your clinics?
It's like one of those. We have like electronic charts. I think you can like change a setting on them, and it just makes the contrast go lower.
Would be kind of cool. I think that's a nice suggestion. I think in our expansion.
Yeah.
I'd like that.
yeah.
That would be interesting to find
I
out if it
think
makes a
a lot more
difference.
symptoms.
Do you guys have it here? Any contrast? Do you do contrast at all?
Our expert of our patients.
Yeah.
Clinic, so I don't.
And you don't buy and sell the equipment, so okay. All right, it's good. Yeah.
And then the final thing is just laser. And laser used to be the mainstay. So focal laser versus PRP. especially in severe NPDR, is sometimes used. Micropulse laser also as well. And then finally, there's the DRS study. They found that PRP was better than observation for PDR/severe NPDR to prevent severe vision loss. And then in the ETDRS, focal photocoagulation for DME, decreased risk of moderate vision loss. Early scatter may be recommended for severe NPDR. And then aspirin use did not, just as an aside, aspirin use did not help with diabetic retinopathy, which is just like an aside from that trial. In terms of the PRP, I'm curious, do you guys do threshold or sub-threshold?
We just have threshold. We don't have any of the sub-threshold lasers. We don't have any of the micropulse or sub-threshold. So we just
No,
laser.
not micropulse, just like not. and
Laser them at sub-threshold. I don't laser at sub-threshold. I might be lazy. I laser. I don't like lasering. Or my eyes get tired. I got dry eye with my. And honestly, when you're lasering, you stare and your eyes drive you crazy. Do you laser?
I laser, I do laser, because when you have patients, especially if you get the feeling like they're not gonna be consistent with their follow-ups, I'll just laser. Advise you time between.
Before NV, before the.
Oh, not before, only if they have NV. I don't treat before.
Yeah, so we don't treat it. We don't treat
No.
severe NPDR.
No.
You guys okay, yeah. So nobody in the room treats severe NPDR. But we
No,
all.
the question was more just like in terms of laser power. Do you go for just whitening, or do you? What I mean by sub-threshold is, I know
Well, that's
some
what I
of
was
the doctors
wondering.
we work with, we
I
reduce
know
the
light.
power.
I think light is just as good, and I think it's easier on the eye. So what I tend to do is I turn it up where I can see it, and then I turn it down a little bit so I see it less. But I do like to see it a smidge.
Okay,
But
yeah, that's what I've heard that referred to as sub-threshold. So that was the question. Yeah.
Yeah,
I feel like with anti-VEGF therapy now, you don't have to treat as heavy as we used to with PRP.
That's true. Vitrectomy is better. And
yeah.
vitrectomy is better.
Yeah, so I do like laser to do just, it's like an insurance policy.
Oh my gosh, yeah, because the patients are so not. I think there's good studies showing, I think Will's had one, I think 25-30% of patients are non-compliant. I can't believe your slide that 30% of the population is diabetic now. That's unbelievable.
That's because of
I heard on the drive-in that 75% of the country.
I think it's less worldwide, but you know, the US.
Yeah, the US. Holy
All
cow.
the fat-free foods of the 80s is now.
Yeah. Any questions on that? That was great. Thank you. That's